Assalamu alaikum. We will start the new session, Refractive Session 2, on title of Lens-Based Refractive Surgery. And today we have me, Dr. Safwan, I'm the moderator, Dr. Ala, Dr. Mohsen, and Dr. Hasna, and Dr. Yahya Salah. And hopefully that Dr. Khalid, he join us or not? No. So we can start with Dr. Mohsen if he is ready. Dr. Mohsen.
Great. Hello, everybody. I would like to thank all the Mayom board and especially Dr. Al-Amri, Dr. Ashraf Armia, and Dr. Safa Jihad for giving me the opportunity to be associated to the prestigious Mayom board. Today, I would like to share with you these cases of unusual indication of pseudophakic toric IOL. Usually the best indication of toric pseudophakic IOL is the association between cataract and stable regular astigmatism as shown in this slide. Personally, for over than 15 years, I have used pseudophakic toric IOL usually when the cataract is associated to an regular corneal stable astigmatism up to 1.5 diopters. I would like to present to you these clinical cases of young patient aged 28 years who was victim of ocular trauma at the age of 8 years with a post-traumatic cataract and corneal wound causing high irregular astigmatism and decrease in visual acuity. The preoperative assessment including the complete ophthalmic clinical examination, including exploration of anterior and posterior segments, given the traumatic context. It's to be noted that in these cases, the ocular trauma caused both the cataract and corneal scar. The tomography of this patient, of the cornea, show an astigmatism which is almost regular with the flat axis at 160 degrees. Fortunately, in these cases, the corneal scar causes a high astigmatism with very important regular components. I would like to highlight the tomography data of this patient, which show a very important component for regular astigmatism, even it's post-traumatic and even it's post-scar and with the wound in the cornea. The question to be asked here, it is possible to correct with a single procedure the cataract and the post-traumatic corneal astigmatism. After giving the patient all information about risk of this kind of surgery, because it's not usual indication to use toric IOL in post-traumatic context, after giving all information, we go to do phacoemulsification with phakic toric IOL. We have opted for phaco with toric IOL because even the astigmatism is irregular and caused by scar and trauma, it has a regular dominant component and the capsular bago is good outside the little fibrosis or again in the wound and normal posterior segment. The outcome was very good with the very good post surgery, and the spherical equivalent was less than 1 diopter, and the corrected visual acuity about 8-10. And of course, the patient was happy and the surgeon also. We showed the slide with the movie with the surgery, and I would like to highlight that to be very careful in this kind of surgery, behind the scar of the cornea, and in this case, the back was very good and very stable back to allowed us to put the toric IOL in the back. It's still debatable question about the indication of pseudophakic toric IOL in irregular cornea, and I think the answer it's into tomographic data. We have to assess, to do a very good exam about the regularity and the irregularity component for all irregular corneal astigmatism when we are planning to do pseudophakic toric IOL. And the pseudophakic toric IOL should be an option if the regularity it's present and it's dominant in this kind of astigmatism. My take-home message, I would like to highlight that if the phakic toric IOL, it's mandatory in the cataract surgery if the regular astigmatism is regular, stable, and up to 1.5. In case of irregular corneal astigmatism, it should be an option, and we have to do very good tomography and to assess the aspect of which is regular and which is irregular. At the end, I would like to again to thank my friend Safa Jihad, my friend Ashraf Arbiya, Dr. Al-Amiri for the kind invitation, and we hope to see you and many doctors from Morocco and from Africa in the next meeting of the MIOP. Thank you very much.
Great, thanks, Dr. Mohsen. That you stick with the time. Hopefully, that I can make it, and I think that I can call Dr. Yahya Salah if he's here. Dr. Yahya, if you are ready to give your session, your presentation, Dr. Yahya. Okay. So if Dr. Yahya is not ready, I think that we will move to Dr. Hasna. And Dr. Hasna will give us today what we call mix and match with bifocal IOL. So Dr. Hasna, please.
Thank you. I will share my
presentation.
My presentation. You see my slides?
Yes, I can see it. Go ahead, Dr. Hasna.
Thank you very much. Cataract surgery is actually a refractive surgery. The patient wants to be independent of their spectacles. So there's many multifocal on implants on the market, some of which are very expensive. Diffractive bifocal IOL is a good deal because good quality of vision and less expensive. The problem that arises with this IOL is that you have to choose to favor either far vision or near vision, and intermediate vision is not good very often. So in our study, we mixed two types of bifocal IOL, emmetropized 1A in order to have nice far and intermediate vision, and myopized other eye to favor intermediate and near vision. So in binocularly, the patient can have a good vision in all distances with less expensive IOL. Our series comport 27 patients, 54 A's with bilateral implantation of bifocal IOL. Exclusion criteria was astigmatism higher than 1 diopter, glaucoma, diabetes, macular disease, corneal disease, when ocular fundus can't be seen, and monophthalmos. Before surgery, we check the uncorrected base visual acuity, corrected base visual acuity, corneal exam with high magnification lens, cataract, zone relief, ocular fundus, topography, biometry with IOL master 700, macular OCT, and specular if it's necessary. We check for dry eye, and we check lacrimal secretion and treat dry eye before surgery. The surgery was classic phacoemulsification with we put the implant on the back, and we check the centering. We ask the patient to look at the light. Which IOL, we put diffractive bifocal lenses. If we can check the dominant A, we put the IOL emmetropization in the dominant A, and the other eye will be myopes by -1. Most of the time, we can't recognize the dominant A because the cataract. So first A operated with emmetropes, and the other A was myopes. Post-operatively, the patients are examined at day 1, day 3, and 1 month later. Visual acuity is measured at stage 3 and 1 month after each for each age. We follow up our patient for 6 months to 18 months. The age is between 55 and 75. We have early postoperative complication like all cataract surgery, corneal edema in 12 eye that regressive after 3 to 10 days in all cases, inflammation in 3 patients also regressive, and late postoperative complications, secondary cataracts in 2 patients with benefited of YAG laser. Binocular visual acuity was good in all distance in 80% of the patient. In 16 percent, they have a good far and intermediate vision but need glasses in the near vision. One patient was very unsatisfied. The monocular visual acuity for the metropized eye is between 810 and 1010, and in myopized eye was in between 610 and 810. 22 patients needs glasses for reading very small scripture, and optical correction with near vision in near vision was +1 to +1.75. We have one dissatisfied cases. It was a patient who was 65 years old. He has 1010 P3 in binocular, but with a very good postoperative refraction, but he was unhappy because he's a jeweler and all his life he has myopia, -3, and he didn't need the correction in near vision. He asked us to give him IOL that can give him myopia, -3 myopia. Halo and Girl, we have this for in 5 patients, especially if they need to drive by night, regressive after 1 year in 3 patients, and no better some in other cases. There's 2 clinical cases. The first one is patient has 68, bilateral nuclear cataract, and we implanted bifocal IOL, myopized left eye, and in postoperatively is very happy, and she don't need glasses. The second case is a teacher, and we myopize the right eye, and in postoperatively he did a small correction to have 1010. So mix and match is to associate 2 different implants or 2 different power of IOL. The goal is for each implant to compensate for the shortcoming of the other. To do this, it's necessary to know the implants and the implants used and their positive and their negative points. Typically, it's advised to place the lens with less addition power in the dominant eye. Seen most uncomfortable photic phenomena happen for distant vision, and these lenses are better tolerated. So we can mix and match all IOL, and it's a promised option for the patient to have good vision in all distance. We can mix 2 bifocal IOL and 2 options. We emmetropize like we do, and if the fabricant has 2 addition 1 year, in 1 year we put +3, and in the other eye we put +4 to favor the near vision. We can also associated diffractive and refractive IOL to give excellent vision outcome, high level of patient satisfactory and spectacle independency, but it needs a period of neuroadaptation. EDOF can be combined with all the IOL, bifocal, trifocal, refractive, diffractive, and other EDOF with good results in all cases. Bifocal and trifocal, it's provide function visual performance at all distance and spectacle independence. So all patients who have undergone mix and match are most often satisfied with good visual acuity at all distance and high level of spectacles and dependency. I want to report these cases. A patient who has 58 years old, housewife, bilateral subcapsular cataracts, and in the first eye we put a trifocal, and we want to put another trifocal in the second eye, but by mistake we put a monofocal in the second eye. The refraction of post-operative was good, and she had binocular uncorrected visual acuity 1010p2. She was very happy and don't want to change the IOL of the left eye and don't want spectacles. So in conclusion, what is the best IOL to offer the best vision to our patient in all distance? I think until now there is no perfect IOL. The best option is to give the best possible vision with the maximum comfort to our patient. Choose the right patient for the right IOL. Never say to your patient, no glasses after surgery. Or don't forget that always under-promise, over-deliver. Thank you for your attention.
Great, thanks, Dr. Hasna. Now, at least you remind us that still we are using the bifocal, the bifocal diffractive, and we will come back to you in the discussion. And I need to ask Dr. Yahya Salah if he is ready. Please, Dr. Yahya, unmute yourself because you are mute. And Dr. Yahya is our colleague, and he's a pioneer in his field, and he will talk about clear lens extraction or refractive lens extraction. Please, Dr. Yahya.
Thank you, Dr. Safwan. It's a pleasure to be with you and a great panel with you. And thank you, Dr. Amri, for inviting me to talk about this topic. Getting rid of glasses is becoming trend. Everybody wants to get rid of the glasses. There are certain choices from contact lenses, laser, phakic IOLs, clear lens extraction. Or the nicer term is refractive lens exchange. So let us focus on this. And definition of clear lens extraction or refractive lens exchange is the removal of non-cataractous natural lens with or without IOL placement as refractive procedure. There are indications that we all are aware of, and we will see this in our practice. High myopia, not fit for other refractive procedures, corneal or laser refractive procedures, high hypermetropia, presbyopia, and this is a huge number of patients that are waiting for a solution, or patients who had previous refractive surgery and becoming presbyope, and this poses another challenge, or younger or older patients with anisometropia that should be addressed. Now there is new terms like dysfunctional lens syndrome, and this is what you see in the eye trace by this staging. So there are patients that are not really, you cannot clinically say they have cataract, but you can diagnose them as a dysfunctional lens syndrome. So how to evaluate any refractive procedure? By accuracy, stability, safety, quality of vision. Accuracy, the clear lens extraction, in spite of all biometric development, is less accurate than that is needed. Stability, it's the most stable refractive procedure available. Safety, it is generally safe, but there are consequences if we don't look for it of drastic complications that we should really evaluate patients properly. And the quality of vision, a clear lens extraction is superior to any corneal refractive procedure. There are contraindications from corneal diseases, retinal diseases, and others, risk factors of retinal detachment or ocular inflammatory syndrome. There are many complications that I'm not going to address here in this talk about complications of refractive lens exchange, from operative problems, post-operative problems, affecting the power of the IOL, quality of vision, retinal problems, inflammations, etc. So there is a huge array that we should be aware of. So how to think of the patient? We should Always when we see a patient coming for clear lens extraction, we see the age of the patient is below 40 years and nothing is valid for him. Remember that he is still accommodating, so try to keep his lens. This should be the last resort. If the patient is older or presbyope or high myope or even hypermetrope, accommodation is getting lost. So this option can be introduced to the patient. We don't push below 40 years, but we can suggest clear lens extraction easily in patients above 40 years. And usually, if we intend to do this, we should do the cases bilateral because of better neuroadaptation, better quality of vision. Preoperatively, like any ophthalmic procedure, cataract procedure, but remember to evaluate properly and treat any ocular surface problem. We should do corneal topography and giant look to detect astigmatism, and this will affect our choice of intraocular lens and higher order aberration, as well as angle kappa and OCT macula to exclude anything that can decrease the vision and again can affect our choice of intraocular lens. Calculations have been talked about earlier, but this is a short list of what we can do, and we have so many options that we can use, and the target, the aim is to be as much as possible on target. We have a huge myriad of choices of intraocular lenses. You have to fashion it and choose the best lens for the patient needs. And you have to talk with the patient because we have so many choices. Patients sometimes come and they have something fixed from advertisement or a friend. You have to talk to the patient, evaluate the patient, and choose the best possible intraocular lens for that patient. Usually, extended depth of focus or extended range of focus are very useful in many situations, but you have again to customize it to the patient needs. Techniques, we are improving in our techniques. We can use very advanced ultrasound. Phaco machines now are very efficient, very safe. And also we can introduce the FEM to cataract for certain steps in the procedure that can help us to get an outcome that we can promise the patient with. And in my opinion, if we're using any of the extended depth of focus or multifocal, trifocal lenses, topical anesthesia is an advantage for better centration, and there is just few tips to center the capsular axis and use the least energy to protect the cornea and definitely protect the posterior capsule, because this is a refractive procedure. You should avoid any complications. So how to think? This is the way preoperatively, type of anesthesia, surgical technique, and post-operative. I will just go through few examples of cases. This is a symphony. A symphony is extended depth of focus lens which is diffractive. And you see these cases are soft, so you have to be careful. Every step should be, you manipulate least, do the simplest technique to be able to remove this lens without jeopardizing either the posterior capsule or the cornea. You can see in soft cataract, it's very simple. If you do proper hydrodissection, and as you saw the capsular axis, you give more time to make it central, because it's very important in multifocals or extended depth of focus to center the lens properly. And as you can see here, one of the things that you should think about is saving the cornea. You can see I'm not using almost any power. It is vacuum. And once you remove the lens, then you shift to irrigation aspiration. And as you can see, I always inject viscoelastic in the time where I change from the phaco to IA to avoid the movement of the vitreous. so as to decrease the chances of post-operative cystoid macular edema. And here the lens is implanted in the back. You can see this is a diffractive lens with this diffractive lens, symphony. You have to remove the viscoelastic from behind as any lens, but this is more. And you see the beauty of having topical anesthesia. You can ask the patient to fix to the light, so you can center the Purkinje image over the center part, and this ensures in a way good outcome post-operatively. Having the femto assisted cataract surgery can help us also to treat, because as you have heard already, that you cannot use multifocal or extended depth of focus in astigmatism more than one diopter. You can beautifully treat this degree from 1 to 3 diopters using femto astigmatic keratotomy, and I use, as you can see here, intrastromal astigmatic keratotomy. So my main indication here to use the femto was to correct the astigmatism at the same time. And in addition, or as a gift, you get a very centered capsulorhexis, very well-sized capsulorhexis, and the procedure is straightforward afterwards. So an addition of the femto second laser in cases of clear or refractive lens exchange is the ability to do simultaneously astigmatic keratotomy, femto-assisted astigmatic keratotomy, and my preference is using intrastromal because there is no pain post-operatively, no risk of infection, and you don't want to put your patient at this, and the efficiency is almost as full thickness in this range of astigmatism. So femto second laser has additional values in multifocal or premium lenses, but in my opinion, one of the main things is combining astigmatic keratotomy. So, and you can use, you have seen so many different types of lenses, the symphony, extended depth of focus, the trifocal, the synergy. Each one, as Dr. Hasna has explained, has advantages and disadvantages. Some have more dysphotopsias, some less, some have continuous range of focus, some have limited range of focus. So in general, choosing the type of lens is very important, so as to choose the right patient and to tell the patient what to expect. This is the mainstay in clear lens extraction, whether for younger patients or presbyopic lesions, or presbyopic patients, they have to know what to expect. And doing the surgery bilaterally, you can adjust, particularly in cases of extended depth of focus, you can adjust the power that you can give them even a nearer or closer range of focus so they can read. Like this is Vivity, for example, you can adjust the other eye to be
myopic side.
Myopic half diopter, so they give them range. Some of the younger patients, I intend to do posterior capsulorhexis, even if they don't have an opacity in the posterior capsule. And this is to avoid doing YAG laser post-operatively, because this can implicate or injure the multifocal lens or the extended depth of focus. And then this lens will really, the patient will suffer from quality of vision. So in younger patients, I intend to do a primary posterior capsulorhexis before implanting the lens. So in conclusion, refractive lens exchange has a role in refractive surgery, very important role, but this role is increasing due to advances in surgical technique and technology, because at one point we were so afraid to do it, but each case has to be planned carefully. Complications are still a concern and has to be considered and discussed with each patient, and you can differ a patient if you see that he's at very high risk of post-operative complication. There are general and specific concerns and complications in each refractive state. Thank you for your attention.
Great, thanks, Dr. Yahya, to be on the time. And with this nice presentation, I think that now it's time for Dr. Khalid Ayyash. I think that he's ready. Dr. Khalid, please. Dr. Khalid, you are ready, right? Dr. Khalid.
Yes, hello everyone. I'm ready. Yes.
Yes, Dr. Khalid will give us
I will
the
start
overview for the premium lens. Please, Dr. Khalid.
I'm sharing my screen.
Yes.
Okay.
Yes, Dr. Khalid. It's okay. Done.
Can you see my screen?
Yeah, I can see your screen.
Okay. Bismillah ar-Rahman ar-Rahim. Thank you for the invitation. I'm happy again to speak today at this meeting. I will give an overview of the premium IOL. First, I will give a list of the available lenses, and I will go through the existing terminology, because nowadays we are hearing a lot of terms by the manufacturer, and we should, as doctors, be aware of these terms. Actually, the first multifocal lenses was implanted in 1986. They have accommodative IOLs. There are many in the market. We have presbyopia correcting lenses, including the multifocal, trifocals, and nowadays we are facing with the EDOF technology, as already mentioned. And we have more than 70 multifocal and EDOF lenses in the market nowadays, or even more than that. We should have, before we start the talk, we should have some facts that there is no lens available or will be available that can resemble the natural human lens. No lens could have zero or complete multifocality. No lens could have a zero photopic phenomena, and no lens that can preserve the contrast 100%. These facts we as doctors should be aware of, and we should take this message to our patients in order to be happy after the surgeries. What are the options for presbyopia correcting lenses? At first, there was the multifocal lenses or the bifocal lenses. We have from Alcon the Restore, from Johnson & Johnson the Thickness, Zeiss they have the Etliza lens, Rayner they have the M-Flex multifocal. Then came the trifocal lenses, the Panoptix from Alcon, Etliza Tria from Zeiss, Rayner they have the Ray 1 trifocals, and the Visual they have the Fine Vision group of multifocal or of trifocal lenses. And then came the EDOF technology. We have EDOF monofocal IOLs. These are pupil independent lenses, like the Vivity from the Alcon. It's a refractive lens. We have the EOHANS from Johnson & Johnson. We have the EyePure from Visual, and we have the X-Acme 4 from Santen. And we have also EDOF trifocal IOLs, like the Oculentis from Lentis. We have Johnson & Johnson. They have the Thickness Symphony, Thickness Synergy, and the Rezoom. Zeiss, they made the Atlara, and the Visual, they had the Fine Vision Trimorph. So these are trifocal EDOF lenses. There are many ways of classifying the premium IOL, like full range of focus. I will not go through these, or the increased range of focus. Now, the EDOF lenses, when we say about the EDOF extended depth of field lenses, this is actually true for only two lenses. When we define EDOF lenses in their pure way, there are only two true EDOF lenses. One is the IC8 from the AcuFocus, and the other is the Morcher, the extra focus from Morcher. And why these are the true EDOF lenses? Because they have the pinhole effect, and this present a small aperture, a spherical surface, and they have a non-diffractive annular opaque mask which block defocused paracentral light rays and allow entry of paraaxial light rays, giving an EDOF effect. It's not pupil dependent. It provides excellent visual acuity at all distances, and the visual field with contact sensitivity, it has insignificant affection al visual field or in the contrast. Also, the IC8 IOL, it has also a small aperture, 1.36 millimeter. Total diameter of the lens is 3.23, and this black area that we can see, it's not a black actually. There is a micro perforation, around 3,200 micro perforation on this one. This is the extra focus Morchar lenses. It's an ODOF lens, and it's intended for ciliary sulcus implantation as a piggyback lens. It's not a lens to be inserted as a only lens. It's as a piggyback lens. It has an overall diameter of 14 millimeter with a central pinhole effect of 1.3 millimeter. It's made of black hydrophobic acrylic, which blocks visible light, but it's transparent to infrared light to permit retinal examination through the opaque material. So if we have a lens inside the patient, still we can see the fundus by the OCT, and this does not interfere with the examination of the posterior segments. So this table summarizes the differences between the extra focus IOL and the IC8 IOL. So these are the two type of true EDOF lenses, and we will come to this. So if we classify the premium EDOF lenses, we have multifocal EDOF, we have monofocal EDOF, which is the aspheric, and we have the pinhole lenses, which are the true EDOF lenses. And also, if there are other group of premium IOL, like the accommodative and the piggyback and the Evo Viva ICL. This is the only one I want to talk here about this, because it's a promising lens. I think it will be in the future. It's like the ICL, but it's intended for those that have monofocal lenses, and so instead of putting or changing their lenses for trifocal lenses, we can keep the monofocal and we can put this over the IOL. And also it's intended to be used for phakic IOL, and it has a very good range from -0.5 to -20 diopter at the spectacle plane. So I think this will be a promising lens in the future. So if you come to the terminology, there is a lot of terms in the field. I think this is a very good article that summarizes the multifocal and the EDOF lenses are available in the market. It's a very good article, and I advise everyone that he wants or he use these lenses to read this article. What about the mechanism of action of these lenses? These could be zonal refractive lenses, could have or could be diffractive, could have small aperture, could be accommodative, or could be combined mechanism of action. The refractive IOL, they are zonal and they are aspheric lenses. Zonal means that there's a distinct region that refract light differently, with refraction determining the way the light rays bend. The optical power is dependent on the local surface curvature. And there is a blend zone where areas of intermediate power to decrease the stray light effect, and they are dependent on the pupil dynamic and sensitive to post-operative decentrations, such as the EUHANS and the isopure are refractive lenses. Refractive lenses, they are aspheric lenses, which means that they increase the negative asphericity of the lens, and this increase the depth of focus, which could be up to 1 diopter or 1.5 diopter. And this increased depth of focus will take advantage of some of the higher order aberrations so as to give a near vision. The diffractive lenses, they are taking advantage of the wave nature of light. So the diffractive lenses, they are two lenses. One is the monofocal lens, and with a top of diffractive surface over this. And this creates a region of constructive interference for the light waves propagating to the retina by selective delaying the optical pathway. Basically, it's a monofocal lenses with an overlying diffractive element. So these are the diffractive lenses. So diffractive versus refractive IOL, the multifocality in the IOL is achieved through refractive or diffractive optical approach. The main distinction is that the out-of-focus light in the diffractive multifocal tends to spread out uniformly over a larger area, as thereby it's less noticeable by the patient, while the out-of-focus light in zonal refractive multifocal lenses is concentrated into rings around the objects and can't be easily suppressed sometimes. There is now hybrid diffractive and diffractive lenses, in which typically the center of the lens has a diffractive structure and the periphery of the lens is purely refractive. The hybrid lenses are usually classified as a diffractive lenses because the center of these lenses is a diffractive lens. And all the approved multifocal IOL use a diffractive ring design for multifocality, but segmented rotationally asymmetric multifocal are still available. The older model of multifocal using a refractive ring design are longer manufactured because of the high rate of unsatisfaction with the patients. The multifocality is achieved through ring-shaped diffractive zones that provide 2 or more focal points. The trifocals IOL introduced to provide an intermediate focal point in addition to the near and the distance foci. They relies on the diffractive multifocal effect. The difference is that the height of the steps are varied in an alternating fashion from one zone to another zone. This pattern has the effect of creating 3 diffraction orders for distance, intermediate, and near foci. More complicated alternating patterns can be used to tailor the amount of energy in each of the foci with as the location. So in diffraction, the manufacturer are playing with the height of the zones and of the diameter of the zone, so that they playing with the which light goes to near, which how much of light will goes to the near and how much of light will goes to the distance. So this is what the manufacturer or the companies change. This is what I mention about the height of the
Dr.
zones.
Khalid, just the time, please, if you don't mind, because we have.
I will conclude 2 minutes.
Please, if you don't mind, because it's there's no 2 minutes.
Okay.
And we have only few minutes for the discussion, and we have presentation more. So if you don't mind, just conclude, please, if you don't mind.
Okay. So there are many existing terminology, and we said extended depth of focus, as we mentioned, extended depth of field, it comes from the camera, and that's why I said that the only true multifocal lens, EDOF lenses are the one with the pinhole effect, because this comes from the camera, where these cameras use a pinhole lenses. I will skip these. So the EDOF lenses is also taking advantage of the asphericity of the eye. So they create more negative asphericity than that needed to compensate for corneal spherical aberrations. And the American Academy of Ophthalmology Task Force has issued a consensus statement that EDOF IOL should have an extended far focus area that reaches the intermediate distance, providing excellent distance and intermediate vision. And it must be understood that aspheric EDOF lenses use asphericity primarily to increase the depth of focus, not the pinhole effect. We are facing a lot of concepts like the edgeless, the X-wave technology, the continuous transitional focus zones. And by this, I will conclude that not every multifocal lens is associated with a photopic phenomena, because many patients are happy and they do not complain of photopic phenomena. And also on the other side, EDOF IOL, they are not free of the photopic phenomena. Thank you very much.
Great, thanks, Dr. Khalid. I think that we will conclude with my presentation, and if you allow me to share the screen. And I think that Dr. Khalid, he makes my journey easier. And sorry.
We can see your screen, Dr. Safwan.
Yeah. Now, you can see now?
Yes, yes.
Okay. So I will concentrate on EDOF-N, and as Dr. Khalid said, that there is a lot of controversy in the terminology, and that's why I will brief what we have, and I think that one of the study that's shown by Dr. Khalid, it was classify the EDOF in a pure way. So why we create EDOF? What was I don't have any financial disclosure here. EDOF, it's created as an extended range of vision, is a new technology in the treatment of presbyopic correcting lenses. The basic optical principle is to add negative or positive spherical aberration. So it is a spherical aberration equal to 1.5 or 1.25 at IOL level, which means 1 diopter, 0.75 at the cornea. That's what it adds. The aim, creating a single elongated focal point to enhance the depth of focus. On the contrary to monofocal IOL, in which light is focused on one single point, or multifocal IOL having 2 to 3 discrete points, these IOL should enhance the intermediate and near visual performance while minimally affecting distance vision. But actually, it provide only intermediate visual performance. Adding more aberration, because someone would say that instead of adding 1.5 diopter negative spherical aberration in the center, we can add more. Here, we will lose the aim of the EDOF by reducing the halos and starburst post-op, because that's one of the aim that we are creating this lens. So might have, because if we will add more negative spherical aberration in the center, then we might have a trade-off which affect the distance vision performance photopsia more than a multifocal overlapping of the percept image with dysphotopsia phenomenon. That's why EDOF trifocal or hybrid appear. So let us go directly to what we call a hybrid EDOF. We have a different types of hybrid EDOF. As Khalid said, we have a diffractive, refractive EDOF, and extended depth of focus added to the extended depth of focus. Now, hybrid as a definition is the best label than that can prescribe IOL combined multifocality, whether diffractive or refractive, with the low addition power to reduce the distance photopsia by adding EDOF technology, spherical aberration, negative, positive, or negative in the low magnitude. Means that in the diffractive, we can reduce the number of the rings, and that is required for a near, and adding a negative instead of those rings. Like, for example, we have a 22, we can reduce it to 9, that's in symphony, and adding a negative spherical aberration in the center, which equal to 1.5. And by this, we will reduce the halos and the post-op, halos and starburst. Now, what we call by, sorry, I'm hiding this by just 1 minute. So hybrid multifocal diffractive, as I said, the rings will be reduced, and instead of this reduction in the rings, we are adding the negative spherical aberration in the center, that equal to 1.5. So by 1.5 diopter required for the rings, like for example, symphony, they reduced from 22 rings to 9 rings, and by this they reduced the photopsia, and by this they reduce this photopsia and the starburst, but still we are affecting the near vision by it. So still now, even with those diffractive multifocal, we couldn't reach to the power of the diffractive near vision, which means that till now, the highest diffractive EDOF can afford less than 2 diopter at the cornea level. Now, what's the hybrid refractive? The refractive is a refractive plate, as Khalid said, and in the center, they reduce that power for the refractive plate by 1.5 diopter, and they add a negative spherical aberration in a way that can reduce the post-op dysphotopsia. Now, a case presentation that reflects the title, that where we can use. Now, I brought one case that is hyperopic, post-hyperopic LASIK treatment. So female patient has 73 years old, post-hyperopic LASIK, both eyes. Patient want presbyopic treatment, don't need to use glasses post-op. If we will look at the refraction, plus 0.75, minus 0.75 at 4, and minus 0.5 for the left eye. Uncorrected is 0.7, uncorrected 0.6 for the left, and visual acuity corrected was 0.8 for right, 0.7. High order aberrations, which I concern about it was a total root mean square 0.5 equivalent diopter for the right and 0.62 equivalent. So it's exceeding the limit of our limitation for the diffractive. Spherical aberration 0.05, and the comma here, which was concerned for me, it was within the limit that I can use some sort of multifocality. So I can show you that this is the right eye where the K reading here, it's reached to 46.5 in one site in the center, as we know that this is the profile of hyperopic treatment. And in the higher derivation for the same eye, the total was 0.5, and that 100% we are concerned about it when we are using that any form of trifocality, even if the hybrid. So here it's still 0.3, and spherical abrasion, it's 0.05. Now that's for the left, and in the left it can reach 48. So I was concerned about the left that she might have a post-op the starburst and halos more than the right. And if we will look at the higher derivations, we can see that the sorry for that. I need to move that again. And we can see that the comma is 0.4. That's why I was concerned about it. Now, in this case, which kind of lens that we will use? EDOF pure. That means that EDOF lens that has, as Khalid said, only spherical abrasion in the center, having addition of 0.75 a cornea, or EDOF diffractive, refractive, hybrid, both eyes, or right eye trifocal diffractive and left eye EDOF refractive, because left eye having more corneal power and higher derivation, or both eye trifocal diffractive multifocal. What I choose is the both eyes EDOF hybrid refractive and lucidus. Now lucidus shows by Khalid, and it's a plate of refractive with the central modified by EDOF. They add a negative spherical abrasion in the center of 1.5, and the power of total power given at the lens level, it was 3. It is 3 by the lens, so it gives us 2.5 at the cornea, and the patient was very happy. The post-op refraction was remarkable for her, and she was able to read and see the distance in a very good way, and she didn't have any concern about the post-op dysphotopsia, whether it's starburst or the halos. So, but it's not mean that we can implant any EDOF hybrid in any patient. As Dr. Salah said, that it should be customized to the patient. So that's why I present this. Great thanks for all. And I think that we will return back to the discussion where we have, I will stop sharing, and the door is open for a discussion. And I think that I will start the discussion with Dr. Mohsen if he's ready, because he presents something saying that the toric lens can be used for an irregular, some irregular astigmatism. And I do agree with him fully, but I need to ask him how you will calculate, which formula that you'll use to calculate this astigmatism, and especially traumatic induced astigmatism of cornea. It will create a lot of changes and varies or variable changes between posterior and anterior cornea. So do you consider a total corneal power in your assessment or in your calculation? Please, Dr. Mohsen.
Yes, thank you very much. I share with you your reflection, but in this case, the corneal scar is in the periphery. So I think for the formula we can like virgin cornea. I think in the center of the cornea, anterior and the posterior surface not change. I think in this case.
So let us say that virgin cornea, you will not consider a total corneal power in calculating the toricity.
In this case, I think I use Barrett formula because it's normal. It's not myopic or hyperopic. Okay. But I show you the results in the postoperative, the spherical equivalent. It was very good.
Yeah. Why I'm concentrating on this point, because this point is very important. The point of the total corneal power is a true corneal power. A Barrett formula is a mathematically measuring or considering the posterior. Now, any question from the audience, or any question, sorry, from the speakers? Dr. Khalid, Dr. Salah, Dr. Hasna, Dr. Safa, she's here, and I didn't say anything for Dr. Safa, my colleague, Dr. Safa. So let me start questioning my dear Dr. Khalid, that I like to question him a lot, and we will say that when we are talking about EDOF and EDOF hybrid, and the case that I showed is a hyperopic treatment, and I didn't show a myopic treatment. In your opinion, which kind of lens that you will prefer in a myopic post-refractive treatment to put if the patient insists that he need a presbyopic treatment?
Usually you should, depends on the spherical aberration. We should, in these patients, we look at the spherical aberration pre-operatively and the RMS values. And if, usually multifocal lenses or trifocal lenses are not a very good candidate in post-refractive surgery, though I did many, and many of them are happy actually, because if the RMS values are within normal values, of the angle kappa is within normal values, then you can use the trifocal lenses. EDOF monofocal is a good choice because you are not dealing with though the spherical aberration will be increased more and more. Usually I try to use panoptics or trifocals from Isopure. From Visual is a good options. But in general, if the RMS values, you can treat them as they didn't do any refractive surgery.
Well, I like your presentation indeed, and I have one point that I like it more, because you said that the hybrid EDOF is not non-pupillary dependent; it's a pupillary dependent, and I do agree fully with you, because I saw few surgeons that they are saying the Synerge or Symphony, they are not pupillary dependent. This is not true. They are pupillary dependent because they are a modified. Now, when we are talking about Synerge, it's a modified diffractive. When we are talking about of Symphony, it's a modified diffractive. When we are talking about Synerge, it's a modified diffractive refractive. The plate is refractive, and the center is a negative spherical aberration, and the posterior part of the lens is a diffractive rings. By it, they increase the depth of focus. Instead of 1.5 of a Synerge, of a Symphony on the cornea, they reach to 2 diopter on the cornea, and that's still not reaching the diffractive power of the near. So I like the refractive hybrid, which it is one of the famous of it, the one that maybe I think that you show it, Lucidus that shows the central negative spherical aberration of 1.5, and the rest of the power is refractive, so it gives 2.5 at the cornea, and it's with me
refractive,
for post-operative, it's with the less spherical aberration. Exactly. Now, one case that we didn't mention it here, patient did LASIK or laser-based presbyopic, and he has a cataract. I think that this subject is very important. I will take 1 minute or 2 minutes just to mention a few things about it. Those patients that they have laser treatment presbyopic, and then they have cataract. Now, which lens, what's the best solution for them? In my opinion, in my practice, I'm using the pure EDOF, because I'm calculating, especially for those that I did the laser-based presbyopia, I'm using Presbymax technique and Schwind, and I know how much that I calculate for the right eye and left eye, and according to that, I'm putting the pure EDOF. The pure EDOF gives them plus 0.75 at the cornea. If we are adding to what's been added on the cornea, then we will end up with a very good near vision and a very good distance vision. I think that we need to close this session.
What type of
IsoPure.
what type of pure EDOF you use?
IsoPure from Physiol.
Okay.
The lens from Physiol, EDOF
Yes.
Physiol.
Safwan,
Yes,
You
I'm
lost the
closing.
connection.
I'm closing.
don't close. I'm not saying
okay.
to close. We are having 15-minute break after
Okay,
this one.
that's
So if you have to
okay.
continue, Dr. Yahya,
Okay.
or another for 5 minutes, it's
Okay,
okay.
good.
Up to you.
That's a very good thing because we have a lot of discussion. Yeah, and
You have
this
to-
is the first time I need to pray. Now I will go to pray shukr lillah because you are giving me 15 minutes. My God, I'm very happy today.
You,
Yes,
you
Dr.
are on the
Khalid, I think
timetable.
that
توصل لك
can
الدكتور
continue.
محمد دائما بتوصل بالدكتور صفوان.
ايوه دائما متوصي فيه.
Dr. Safwan, he
إيه.
take 2 minutes or 3 minutes more than others, but no problem.
لا
He
حول
can.
ولا قوة إلا بالله. يلا, okay. Now, I think that,
Dr. Yahya, Dr. Maxim.
as Dr. Khalid was saying that if you are going for example, for Vivity or for IsoPure or for any other lens that have the pure negative spherical abrasion in those post laser-based correction of the presbyopia.
High management.
Sorry, who's talking? I don't know. Dr. Hasna? No. Anyway, what we are concerned is that the surgeon that he did the laser base, he calculate and he know how to what he did. But if the patient coming, he did the laser base presbyopia, how we will calculate? Well, we need to go through and because for me, I have the MS39 and I can calculate the amount of the negative spherical abrasion. Because what we are doing in a laser base, we are creating a negative spherical abrasion, the same as what's there in the diffractive. And that amount of the negative spherical abrasion will appear in your high order abrasion sheets. So you can at least reach to a certain calculation that equivalent to the power that will add. Like, for example, we have a max of 2.5 diopter add in some cases. And according to the history of the patient, I'm asking which machine that he used in which center, so I can imagine and I can reach to the calculation of the power that's been added to the right and the left. In one case of mine, the patient came from other center that he did Presbyon, and I know that Presbyon that they are doing not more than 1.5 add in one eye, and the other eye it's some form of micro monovision or monovision, and they add they correct only the refraction in the other eye. So in the eye that they correct only refraction, where my high order abrasion sheet doesn't show a negative spherical abrasion, I put a lucidus. And in the eye that has shown a negative spherical abrasion enough on the cornea that can correct around 1.5, I add only a pure hybrid, pure EDOF, where it gives the patient adding plus 0.75 at the cornea, and he's already having plus 1.5 in his cornea. So at the end, he will have 2.25 in the right eye and 0.7 and 0.75 in the left eye. So it gives him a multi-range, and the patient was happy for a distance and near. That's what I was. So Dr. Salah, any comment? Salah, Dr. Yahya Salah? Just unmute, please. Unmute, please. Yeah.
I agree with you, of course, but you have more luxury than we have. We don't have all these types of lenses. We have enough variations, but it's very important, at least as broad lines, to know if the patient was myopic LASIK or hypermetropic LASIK. So at least to not use aspheric if he for a myopic patient, and and you can use aspheric for a hyperopic LASIK. Who have done a hyperopic.
Exactly. Yeah. Dr. Mohsen, any comment?
I have a question for all the panel, if you excuse me,
Yeah.
about we discussed about this situation yesterday with Dr. Amri. You have many
Yeah.
patients now. They are very unhappy with one eye, one monofocal IOL. They are very unhappy. Why? They have
Yeah.
not good vision, intermediate and near. With
Yeah.
What about the second eye? Which kind of IOL will advise to go direct to myopia, micro monovision, or but about EVO with fake IOL in this first eye? This situation is very frequent in my country. Many patients, they come with monofocal IOL and they're not happy. I ask about this new IOL.
Yes. If allow me to answer, or Dr. Yahya Salah, I think that he has some comments. So let us start with Dr. Yahya.
Yeah, it's really a common
Exactly.
situation that we see.
Yeah.
But the problem is, if you are going to choose one, an extended depth of focus maybe is a good option, but we have to tell the patient most of the time, like 95% of the time, I will use many monovision, micro monovision, and the other eye monofocal. And my standard monofocal lens is eye hands. So eye hands, without telling the patient, it really, if you have this difference, like half a diopter difference, it gives them acceptable range of vision. So it's not my first choice to use a premium lens on the other eye, because there will be more difficult adaptation, and then it will be a problem that the patient will come and complain. So we will add more problems.
Okay. Dr. Khalid?
Yes, I totally agree with what mentioned by Dr. Yahya. If a patient has a monofocal lens, then I will not advise to do a trifocal lens in the second eye. The other option is to use the EDOF lenses, which can be a neutral balance between both. For the EVO, the ICL is another option, but I don't think it's still available in the market. It's in Jordan, it's not available.
Hopefully it will be. You mean that the biggie bag from Rainer?
Big bag. No, the big EVO ICL from the ICL.
EVO ICL. No, ICL, I'm talking. Yeah. So if you allow me, we can
have the Sulca Flex and the other options, but they are big lenses.
Yeah. So if the posterior capsule was intact for this patient, and the high order abrasion of this patient allow him for a diffractive lens, well, I will discuss the matter of lens exchange, and that's what I did. The patient was a lady, two ladies. They came and they been implanted a monofocal, and then they thought that the surgeon implant trifocal, and then they shocked that they are not reading, and then there was a big trouble with the surgeon, and so they came. And when I studied the cornea was compatible with the diffractive, and the posterior capsule was intact, and the surgery done at least 1 month, so I could separate the lens and exchange with the trifocal. But if the patient came and the posterior capsule was ruptured, or they did YAG capsulotomy, and the cornea was still compatible with, then I will go to biggie bag from Rainer, trifocal piece only. And that trifocal piece, it will add only the trifocality and the centration of it. It's a beautiful lens. You can order it from Rainer. Now, if the patient cornea was not compatible to the diffractive and any changes, then I will go to deal. Definitely, the delt of the other eye will be the same as what I will do in this eye. Now, I have few cases that they sorry.
The time is over, if you don't mind already.
Okay. I just need to 1 minute from you, if you have. You give us so one case that the patient insists to do a laser correction after the lens-based correction. The lens was monofocal, and Presbymax module did a very good job, and the patient had 2.5 add on the cornea on a monofocal, and that definitely you need a good study for the visual axis and a track system that can assess the cornea, and we succeed in that. So in case that the cornea was not compatible with the trifocal, I will do a Prisbimax for this eye. Definitely the second eye will be according to what's the second eye compatible, either with a diffractive or EDOF. Great thanks, Dr. Muhammad, for this luxury time that you give us to us, and great thanks for the audience and for the panel with the best discussion that done and best presentations, and see you in next meeting. Thank you.
Thank you, Dr. Safwan,
Thank
Dr. Mohsen, Dr. Yahya,
Salam.
Dr. Khalid, Dr. Hasna. Thanks a lot for an excellent session. See you, inshallah.
Inshallah.
Inshallah. Assalamu alaikum.